We start by entering the abdomen through an incision that we make in the upper midline or in the middle of the belly. In order to expose the head of the pancreas and the duodenum, we'll move the colon out of the way. The duodenum wraps around the head of the pancreas, and these two are pretty well stuck together, so we have to remove, if we're removing one, we remove both. We start by performing a Coker maneuver, which is to free up the duodenum and head of the pancreas, and this allows us to identify the inferior vena cava. The vena cava is the largest blood vessel in the body and carries blood from the lower half of the body back to the heart. Next, we'll remove the gallbladder. We'll divide or cut across the intestine in two places, as well as the neck of the pancreas and the common bile duct, and remove the specimen. We'll send this off to our pathologist to make sure we've removed the tumor. Next, we put everything back together, and we do this by putting a piece of intestine and connecting it to the pancreas, called a pancreaticojejunostomy. We connect the bile duct to the intestine, called a choledochojejunostomy. And then finally, we'll connect the stomach back up to the intestine, and this is called a gastrojejunostomy. One variant of this operation is to leave a little bit more of the intestine, this is called a pylorus preserving Whipple, and we'll connect the pylorus up to the intestine.
Surgery. The pancreas is an organ that is found behind the stomach. The pancreas makes hormones and digestive juices that help the breakdown of food. The pancreas is attached to the first part of the small intestine, the duodenum, the arteries and veins that supply or drain the liver and intestine, and the bile duct. The gallbladder is a small organ that helps digest fat and stores bile made in the liver. It is attached to the bile duct and is close to the pancreas. The pancreas and the gallbladder empty digestive juices and bile into the duodenum through the pancreatic duct and common bile duct. This helps digest food that is coming from the stomach. The pancreas is in front of two major arteries that supply blood to the liver, pancreas, stomach, spleen, and intestines. These are the celiac artery and the superior mesenteric artery. Beside these arteries are the superior mesenteric vein, which drains the intestines, and the splenic vein, which drains the spleen. These two veins join to form the portal vein, which opens into the liver. Pancreatic cancer happens when cells in the pancreas change and begin growing uncontrollably, forming a cancerous tumor. The most common form of pancreatic cancer begins in the cells of the pancreatic ducts that make digestive enzymes. This is called pancreatic adenocarcinoma. There are many other forms of pancreatic cancer, including cancers that begin in the bile duct, called cholangiocarcinoma, or from the cells that make hormones, called neuroendocrine cancer. Different types of pancreatic cancer behave quite differently. Individuals with pancreatic cancer often have jaundice, which is yellowing of the skin due to a blockage of the bile duct. People with pancreatic cancer can also have pain and weight loss, although some have no specific symptoms at all. Pancreatic cancer can be treated with several approaches. If there is no evidence that the cancer has spread beyond the pancreas, the cancer can be removed by surgery. After surgery, further treatment, called adjuvant therapy, which may involve chemotherapy, is often recommended. Surgery is often needed for tumors in the head of the pancreas. The standard operation is called the Whipple procedure. In the Whipple procedure, you will be placed on an operating table and given a general anesthesia. Several tubes will be inserted for monitoring and for giving medications and fluids. These will include an arterial line, an intravenous or IV line, and a central venous catheter. A urinary catheter will also be inserted into your bladder and a nasogastric tube will be placed in your stomach. All of these tubes and catheters will be in place when you wake from the anesthesia after the surgery. They will be removed as soon as possible. The procedure starts with either a vertical cut or incision of your upper abdomen, or a horizontal incision below your ribs. After the incision, your abdomen will be checked for signs of spreading of the cancer. If the cancer has spread, a Whipple procedure will not be performed, and a bypass operation may be performed instead. If there is no sign that the cancer has spread, the Whipple procedure will be done. In order to remove the head of the pancreas where the tumor is located, the pancreas will be split at the neck. The procedure involves removing the end of the stomach, known as the antrum. In certain cases, the antrum is not removed. Removing the entire duodenum. Removing a small amount of the second part of the intestine, known as the jejunum. Removing the gallbladder, and removing the common bile duct. In some cases, the vein behind the pancreas may also have to be cut. Once the tumor and pancreas head have been successfully removed, the gastrointestinal tract will be put back together. This will include repairing any parts of the intestines, bile duct, and any veins and arteries involved. There are 5 steps to the repair process. Step 1. If the vein was cut, this will be the first thing to be repaired. Step 2. The remaining pancreas and pancreatic duct will be connected to the jejunum. A plastic tube may be used to keep this connection open. This tube will be left in place after the surgery and does not cause any harm. Step 3. The bile duct is joined to the jejunum further down. These 2 connections will allow digestive juices and bile to flow into the gastrointestinal tract again. Step 4. The stomach, or first part of the duodenum, is connected to the jejunum still further down, which will allow food to pass through. In some cases, a drain will be placed close to the new pancreatic and bile duct connections. Step 5. The abdomen will then be closed, and the skin edges will be brought together with either stitches or stainless steel staples. The Whipple procedure usually takes 4 to 8 hours to complete. As with any surgical procedure, there are risks involved. These risks include, but are not limited to, about 10 to 20 people in a group of 100 may experience bleeding, and the same number may develop infection. About 5 people in 100 may have a deep vein thrombosis or blood clot in a major vein. 1 or 2 people in a group of 100 may get a pulmonary embolism or blood clot in the lung. At UHN, about 2 people in a group of 100 risk death as a complication of the Whipple procedure. Other complications specific to this procedure may include vomiting due to delayed gastric emptying, bile leaks, pancreatic leak, insertion of a drain for infection or a leak, re-operation for bleeding, infection, or a leak. Diabetes is a condition in which a person has high blood sugar. Hallmark symptoms of diabetes include increased frequency in urination, increased thirst, and increased hunger. For most people, the part of the pancreas that is left behind will produce enough of the hormone insulin so that diabetes does not occur. However, the Whipple procedure may lead to a new diagnosis of diabetes or worsen the symptoms of diabetes for those who already have the condition. Although rare, prolonged diarrhea is more likely if you have a larger pancreatic tumor that required vein or arterial resection and reconstruction, or both. Your diarrhea may get better if you take pancreatic enzyme replacement. The recovery process typically lasts 5 to 6 weeks. It may be difficult at the start, but will improve with time. After the Whipple procedure, you will have several tubes and catheters, including a nasogastric tube, an intravenous or IV line, a urinary catheter, a central venous line, an arterial line, and a heart monitor. Your nasogastric tube will be removed as soon as possible, often on the morning of the first day after your surgery. You will be encouraged to walk on this day as well. A clear liquid diet is usually started when your intestines begin to work again, often on or around the third day after your surgery. Most patients are able to return to a regular diet over the next 24 to 48 hours, though your surgeon may prefer to keep you on a liquid diet for longer than that. If a drain was left in place, this will be removed if there is no suspicion of pancreatic or bile leaks. Most patients are discharged from the hospital within 6 to 10 days after a Whipple procedure. Your incision staples will be removed about 7 days after your procedure, either in the hospital or by your family physician. Some patients who have undergone the Whipple procedure will need pancreatic enzyme supplementation to help with fat digestion. You should expect to have several watery bowel movements a day for some weeks following discharge from the hospital. This will decrease as your gastrointestinal tract readjusts. Most patients will eventually have normal bowel function. You may also experience occasional bloating, indigestion, nausea, and vomiting. In time, most patients return to their normal lifestyle and bowel function. You should not lift anything heavier than 10 pounds for 6 weeks after the operation. On returning home, you must contact your family physician or surgical team if you have any of the following: a fever over 38 degrees Celsius or 100.4 degrees Fahrenheit, an unusual amount of pain, pronounced nausea, vomiting, or diarrhea, or you cannot eat properly, jaundice, yellow eyes, dark urine, a red and painful surgical scar, or one with a smelly discharge. If you cannot contact your physician, you should go to the nearest emergency room. You will meet with your surgeon about 4 weeks after the Whipple procedure to review how you are doing and to go over the results of the tests done on your tumor. At this time, your surgeon will talk with you about the need for further treatments.